Hello, my name is Heather Rosser, and I'm a public health nurse currently working for the Children First program through the Oklahoma City County Health Department. For this staff development activity assignment, I'd like to think about ways that we might keep nurses who perform home visits safer by increasing their awareness of both dangerous and safe practices. This presentation offers suggestions for how a nurse safety training program might be incorporated into my workplace. So let me begin with a roadmap of where we're going to be traveling for the next several minutes. First, I'll share several learning objectives that a staff development activity like this might adopt. Then I'll let you know a little bit about the Children First program and describe our responsibilities as nurses who perform home visits. Next, I'll describe safety concerns for home visit nurses generally and for Children First nurses specifically. Finally, I'll present a discussion of both dangerous and safe practices for home visit nurses and offer suggestions for assessing learning through a brief comprehension quiz. The main goal of this staff development activity is this. Through this training, I hope to raise nurses' awareness of both safe and dangerous home visit practices so that Children First nurses will be better equipped to keep themselves safe on the job. So for a staff development activity designed to increase awareness of both dangerous and safe practices, I envision the following learning objectives. First, participants will be able to describe common threats perceived by nurses who conduct home visits. Second, participants will be able to name threats more common to Children First nurses. Third, participants will acknowledge neglectful or thoughtless practices that increase their risk of danger during home visits. And fourth, participants will identify key strategies for helping keep themselves safe on home visits. Fulfillment of these objectives will be measured by a brief assessment interview described at the end of this presentation. To begin with, I will describe the Children First program not only in order to inform, but especially in order to demonstrate how I would initiate a staff development activity by intentionally fostering a sense of camaraderie among fellow nurses by validating their work and acknowledging the risk of home visitation. For the past year, I have worked in the Children First program for the Oklahoma City County Health Department. Children First is the Oklahoma branch of the National Nurse-Family Partnership Program. Nurse-Family Partnership is an established program whose benefit is evidenced by years of empirical research. In Oklahoma, the program is called Children First. We partner first-time mothers with a specially trained registered nurse who will provide brief health assessments, growth and development assessments for infants, case management services, and health education centered around the mother's needs and desires. Services are provided in the convenience of the home. Nurses in our position provide the following services for clients. Mothers, babies, and families are our clients, and we do this in their own homes. Health education, including risk factors for certain conditions in the prenatal, perinatal, postnatal, fetal, newborn, infant, and toddler health education. Nutritional and healthy weight education, including prenatal, while breastfeeding, and newborn through toddler. Sex education, family planning education, and goal setting, breastfeeding education, parent coaching, case management, health assessments, and developmental assessments. It's definitely rewarding to help clients learn to help themselves, to empower them to reach the goals they have set, and to put them in touch with both education and resources for a healthier lifestyle. But I've come to realize that instead of working with one patient at a time, public health nurses work with communities of women and families. Home visits offer an opportunity to breathe the patient's own air by experiencing their living conditions. Yet visiting patients in their own homes and communities can be dangerous, as will be described in a moment. Still, Children First nurses believe that the work of nursing is important and that care should be provided for those who need it regardless of location. We are instructed to be cognizant of our surroundings, always proceed with prudence, and take precautions to ensure our safety. Regardless, we believe that the Children First program is worth some risk because these women, their babies, and their families are worth it. Nurse-Family Partnership and the Children First program are, in my opinion, high-quality, intentional nursing care that empowers the disadvantaged with better health, increased education, and improved opportunities for flourishing. Specifically, helping to establish positive attachments between mother and child and improving the health of families is a job we are excited and humbled to perform. An article on nurse safety during home visits begins this way. A client's angry and drunken spouse who pushed the nurse out of the door and down the front steps. A bedridden client who warns the nurse not to surprise him because he has a gun in his bedside table. Dogs growling, chasing, or biting at the heels of nurses. Most nurses who work in the community have heard stories like these, and all too often, nurses have similar stories of their own to tell. She goes on to describe the results of her extensive survey research into the risks and experiences of home visit nurses. She found that primary risks identified by nurses include dogs, the necessity to carry heavy and awkward equipment to and from the car, walking hazards, unsafe homes and buildings, having to work alone, traveling by car, exposure to infectious diseases, and the threat of abuse, whether physical, verbal, or sexual. She reports that dogs were perceived as a risk to personal safety by nearly 90% of respondents. Over 3/4 of the respondents had been threatened by a dog, and 1 in 6 nurses reported sustaining an injury from an animal. Other researchers put it this way. When a field worker enters a home visiting situation, she or he brings a certain degree of uncertainty and ambiguity from such contextual and or situational factors as population density in the area of the visit, whether it's rural, suburban, or urban locations, racial and economic instability, evidence of illegal drug use or trafficking, urban decay, and transient boarding houses. Groups of people congregated in doorways, at street corners, outside of bars and storefronts, roaming or vicious dogs, media reports of crime and unrest, and the absence of safety resources such as police and security patrols increase the field workers' perception of uncertainty. Prior experiences in home visiting may or may not be helpful if the environment is viewed as posing risk to personal safety. And among Children First nurses, it is likely that each nurse has experienced situations or people that have made her feel unsafe and vulnerable. Children First nurses are called on to go into neighborhoods that are known to be violent, enter homes in which unknown people other than the client may be present, and possibly spend hours in high-crime areas. I have heard stories of nurses hearing gunfire just outside the client's door, discovering that a strange man had entered the client's home through a back door during a visit, and all kinds of dealings with domestic violence, drug abuse, and unpredictable clients, especially those who struggle with mental health. The reality is, being a home visit nurse is a dangerous job. It's up to each nurse to increase his or her awareness of both dangerous and safe practices. Of course, if there were an actual safe staff development activity, I would at this point ask participants to swap stories, to share experiences with one another for the sake of team building. At this point, I would begin a discussion of safe and dangerous practices for home visit nurses. Before supplying them information from research or a list of best practices, I would invite participants to brainstorm with me so that collectively we might generate ideas relevant to our own context. Following the brainstorming session, I would augment our list with the following recommendations from relevant literature. Dangerous practices for home visit nurses include 1. Lack of adequate training for nurses and lack of policies to help protect nurses and prevent risk of danger. As one researcher says, training should cover the agency violence or safety policies, risk factors for assault, ways to deal with hostile household members, verbal de-escalation techniques, hazard control strategies, and reporting policies. Training should occur upon hire and annually thereafter, but also can be integrated into staff meetings. As nurses, we should encourage our employers to continue to invest in training and development in regard to risk assessment and safety protocols for home visits. Number 2, on the other hand, not utilizing safety measures or disregarding policies devised by the Children First administrators. According to McFall, Lipscomb, and Johnson, many employers provide safety policies and services that are up to the discretion of the staff to utilize. such as cell phones, escort services, paired visits for high-risk households, but staff do not always avail themselves to these safety services. Number 3, poor record keeping and/or reporting practices. Number 4, general lack of awareness about the communities and neighborhoods comprising your home visits. Belay makes the following recommendations to reduce risks on home visits. First, the key to reducing risk for community nurses during home visiting is effecting a change in attitude by organizations, clients, and nurses. The safety of nurses must be recognized as a priority by the organization. Nurses should not be expected nor expect themselves to enter unsafe situations. And patients need to understand that their right to receive professional health care in the home must be balanced with the right of nurses to have a safe work environment. Second, best practices for home visiting safety and safe work procedures must be implemented. Risk assessment should be done prior to home visiting and consideration given to options such as accompanied visits, visiting at a safer location, or refusing the visit. Appropriate equipment such as cellular phones or personal alarm systems must be made available to home visiting nurses. Third, orientation and continuing education of community nurses must include risk identification, best practices for nurse visiting safety, and safe work procedures. Fourth, supportive policies are needed such as zero tolerance for staff abuse, no driving in inclement weather, and no contact with pets. I will also provide participants with a risk assessment tool developed for home visit nurses. After reviewing the tool, I'd like to engage participants in a conversation regarding the practicality and applicability of such a tool in our context. The purpose here is not merely to provide them with a tool, but to help them think critically about risks in our actual situation as Children First nurses in Oklahoma County. In order to assess fulfillment of learning objectives, at the end of this staff development activity, I would encourage nurses to break into small groups for collaboration. Because I am aware of the collaborative work culture at Children First, small group and team-based assignments are a good strategy for this organization. In their groups, nurses would work together to respond to the following prompts. Number 1, describe common threats generally perceived by nurses who conduct home visits. 2, describe several threats common to Children First nurses. 3, identify several neglectful or thoughtless practices that increase risk of danger during home visits. 4, name several key strategies for keeping safe on home visits. Likely, we would then discuss results collectively. My hope is that through this staff development activity, Children First nurses will become more aware of both safe and dangerous practices, and that increased awareness will keep them safer during home visits.